good morning, everyone. This is Dr. Samira Khan, one of the study medic mentor. Today, our topic is benign gynecology, and I'm going to discuss two guidelines with you. First is the heavy menstrual bleeding, and the other one is the postmenopausal ovarian cyst. So let's start. The quote of the day. So work hard, dream big, and never give up. So let's start with heavy menstrual bleeding. This is the guideline, NICE guideline. So this presentation is based on this NICE March 2018 guideline. So the definition of heavy menstrual bleeding is just excessive menstrual bleeding. So it is subjective, not objective. And it is defined by the impact on quality of life. So we will not say, like we used to say, more than 80 ml, more than 100 ml. No. So it is subjective. So first, when the patient comes with the history of heavy menstrual bleeding, we have to do the examination. And in examination, we look for the vital signs, blood pressure, we look for the BMI, then abdominal examination, pelvic examination. Pelvic examination is important because we need to see the uterine size and check for any masses or tenderness. For example, if the patient is having enlarged uterus or the signs of adenomyosis, so maybe we will ask for ultrasound first. So in history, the bleeding, nature and duration of bleeding will be asked. If there is any intermenstrual bleeding or not, we have to ask for any pain or pressure symptoms. Why we are asking all of these information? Because to rule out, especially if there is intermenstrual bleeding, to see maybe there are any polyps, endometrial hyperplasia, carcinoma, pain or pressure symptoms might be due to the fibroid. And now this is very important to ask if the patient is having any fertility wishes, because the management depends on this. And the medication history, like if she's on HRT or not, if she's on tamoxifen, which is a breast cancer treatment. Okay. So what are the lab tests that are important? Now, why the full blood count is mandatory? First of all, we have to find out that her perception of heavy menstrual bleeding is true. So it is affecting her not only quality of life, but if it is also affecting her hemoglobin, which will be like objective proof of what the patient is saying. But also to know that if she need iron like supplement or not, and if she is going for any surgical management, then this will be especially important. And if the patient is going for any surgical management, then coagulation screen might be, or if she is having any what you call factor 8, like 1 Willebrand's factor symptoms like epistaxis or and the gum bleeding, then we can also ask for some factor like 1 Willebrand factors. Thyroid function test. The patient who has other symptoms, sinus symptoms of hypothyroidism, we can also ask for thyroid function test. Otherwise, it's not routinely needed. And there is actually no routine hormonal profile. So nothing is routine except full blood count. What are the red flag? The red flag, if the age of the female is more than 45 years and she has some new or worsening bleeding, and if she has persistent intermenstrual bleeding. So if the intermenstrual bleeding is 1 or 2 cycle, it can happen even with stress, hyperlectin, temporary cause, can have intermenstrual bleeding, but if it is persistent, then this is worrisome. If she is obese, having PCOS, which increases her risk of endometrial hyperplasia and carcinoma. She's breast cancer on tamoxifen increases her risk of endometrial hyperplasia and carcinoma. And if she tried all the medication and all the treatment fail, these are all red flag silent symptoms. So after examination, if we think that the patient has some kind of pathology like fibroids or adenomyosis or any kind of endometrial hyperplasia or carcinoma, according to the history and examination, then the best is hysteroscopy, and an outpatient is the best. If the patient decline, then we can perform under regional or general anesthesia. And so if the patient is having large uterus or pelvic mass, then we have to go towards the pelvic ultrasound. And if the patient is having adenomyosis sign and symptoms, then it is very important to ask for transvaginal ultrasound. And if the patient is high risk for endometrial hyperplasia or carcinoma, then we should take biopsy during hysteroscopy. If the fibroids are less than 3 centimeter, or if there is no pathology, or maybe if there is adenomyosis also, our first line management will be levonorgestrel intrauterine system, which is Mirena. It will improve quality of life, but we have to wait for 6 cycles for its full effect. There are other non-hormonal options like tranexamic acid and mefenamic acid, which is the NSAID. If the female wants to get pregnant, then she can opt for non-hormonal options first. There are other hormonal options if she doesn't like to have this IUS system. So, which is combined oral contraceptive pill. If she wants contraception and she wants to reduce her bleeding, then she can opt for combined OCPs. Or if OCPs are contraindicated, then she can also go for, or if she doesn't want to have combined pills because of side effects, then she can also go for oral progestogens and POPs and Depo-Provera injections, because sometimes Depo-Provera can worsen the bleeding in 10 to 20% of the patients, but most of the time it will reduce the bleeding and can also cause amenorrhea. So if the fibroids are more than 3 centimeters, so we have to refer the patient for the specialist care. So the GP, it's out of hand of GP, so the gynecologist needs to see this patient. And if the fibroids are more than 3 centimeter, even 3 centimeter, she can have different options of treatment. Like she can take non-hormonal if it works, like tranexamic acid and mefenamic acid. And she can also have the hormonal choices like Mirena, OCPs, cyclical progestogens, and ulipristal acetate, which can shrink the size of the fibroids also. But it can lead to liver injury, so we have to monitor the liver function test at least for the first 2 courses of ulipristal acetate. Also, uterine artery embolization can be tried for this patient, and the other options are myomectomy and, at the end, hysterectomy if nothing works or if she complete her family. So endometrial ablation can be tried also, and we prefer second generation, but she has to avoid pregnancy. She has to use contraception. But if the cavity is very large and distorted, then it's not a good idea. So hysterectomy counseling, we have to inform the patient that it's going to take away her fertility forever, and we can give her an alternative option of myomectomy. And also we have to discuss the surgical risk of hysterectomy, and also the things that needs to be discussed before this procedure is the routes like vaginal, laparoscopic, whatever the patient prefers. So we also need to discuss that most probably we'll go for total, but sometimes it is not possible, and because of adhesions or whatever reason, or maybe the patient start to bleed. So we can go for subtotal also. So it needs to be discussed at the time of consent. And then talk about the ovarian function, like sometimes after hysterectomy, the ovarian blood supply is compromised, and the patient can go into premature menopause, and also uh, talk with her about taking out the ovaries or not. If she has high risk of ovarian cancer, family history, then this is the thing that needs to be discussed with the patient. Now, before you go for hysterectomy, it's a good idea to shrink her fibroids by giving her GnRH agonist or ulipristal acetate, um, just to reduce the bleeding and complications during the surgery. So it's a nice flashcard of heavy menstrual bleeding management pathway. It just says the same thing, but it is just in the form of flashcard. That if the patient reports menorrhagia, we have to take history, examine full blood count, which is the only test. Other sign and symptoms of hypothyroidism, so we can also ask for thyroid function test. If she has abnormal pelvic examination, then and she desired pregnancy, then we can go for non-hormonal medications. If she's not desiring fertility or pregnancy, then we can go for other contraceptive options. The other option is, if the abdominal pelvic examination is not normal, then we can ask for pelvic ultrasound. If the uterine size is very big, it is tender, um, so we can ask for abdominal ultrasound to see if there are uterine fibroids or not, and also refer for gynecological opinion. So the causes of hemimenstrual bleeding in the uterus can be fibroid or adenomyosis. In the endometrium, it can be a polyp, hyperplasia, carcinoma. The ovaries can have PCO. Maybe the patient become obese. There's a weight change, lifestyle changes happens, and she's hypothyroidism. So this can be the cause of heavy menstrual bleeding. And some exogenous causes, like having bleeding disorders, like this von Willebrand disease, or maybe she's using warfarin, which is anticoagulant, or some heparin or something. So what are the red flags? Like we discussed, if there are any red flag, we have to refer the patient for gynecological assessment. Okay. So heavy menstrual bleeding, quality of life. We have to see if it is affecting her quality of life or not. Hysteroscopy can be done if we are suspecting endometrial hyperplasia or carcinoma, but otherwise, if we are suspecting structural abnormalities like fibroids, then we can go for the ultrasound. But it is not advised to do blind biopsies, only under hysteroscopic directed biopsies. So let's do some SBAs. A 38 years old woman presents with heavy regular menstrual bleeding for 8 months, but no pathology is found, and she completed her family. So what do you think is the first line management? She's 38 years. She has a regular bleeding. There is no intermenstrual bleeding, and it's heavy. No pathology is found. You can think, and we will look at the answer. Okay, so the answer is, according to the NICE guideline, is the Marina. So a 47 years old woman presents with new heavy bleeding and intermenstrual bleeding also, and she's obese. So what is the most appropriate next step? So what do you think? We will look at the answer now. Hysteroscopy with biopsy. Of course, not blind biopsy, because she is 47 years old. So it's a red flag. More than 45, age is more than 45 is a red flag. And and she required endometrial assessment for sure. She has intermenstrual bleeding, obese, age more than 45. So, a 30 years old woman with heavy menstrual bleeding, she wishes to conceive soon. No pathology found. So, she has desire for fertility desire. So, of course, we cannot give her any contraception, right? Tranexamic acid, non-hormonal. A 42 years old woman with heavy menstrual bleeding and the largest fibroid is 5 centimeters. So what's the most? Now she has fibroid. Specialist referral. So we know that if the fibroids are, so GP cannot handle it anymore, so he has to refer it to the specialist gynecologist. So if the fibroids are 3 centimeter or more than 3 centimeter and she is symptomatic, then she might need some type of invasive or minimal invasive procedures. Sorry. So the last one, what is the most accurate investigation for polyps? What do you think? Again, gold standard for any cavity lesions. Hysteroscopy. Anything in the cavity, either it is endometrial hyperplasia, carcinoma, polyp, even intracavitary fibroids, hysteroscopy. So let's talk about the second guideline, which is the ovarian cyst in postmenopausal women. Now, there are two guidelines about it. We will base our information on RCPI guidance 2016, but just for your reference, I will include some information from the Green Top guideline about the same topic, which is recently updated in December 2025. Why the ovarian cyst in postmenopausal women matters. So, because ovarian cancer is the fifth most common female malignancy, and it usually occurs after 50 years of age. And it presents late. So that's why it's called a silent killer, because it presents late in stage 3 or 4, and it has high mortality. So we have to do risk management index accurately and go manage according to this. It will improve the survival rate. So what are the risk factors that can cause ovarian cancer? So if the patient is having early menarche, late menopause, she's on HRT, or some familial genetic BRCA1, BRCA2, or Lynch syndrome, nulliparity, PCOS, history of breast cancer, all of these things are the risk factors. Obesity, smoking, she went through fertility treatment, or she never used oral contraceptive pills. So she can have ovarian cyst, which can be uh, malignant. So in postmenopausal women, if you find ovarian cyst, you should be worried. It's not always cancer, but you have to rule out cancer. And whatever we will do, we are ruling out cancer. In premenopausal females, if there is an ovarian cyst, it's almost always benign. Okay. So what's the initial investigation? If you find an ovarian cyst, it will be serum CA-125. And if you ask for like transvaginal scan is the preferred choice, if the cyst is very large, it should be transabdominal should be added also. Now, if the patient is having family history of ovarian cancer, it is better to refer this patient or the ovarian cancer and the breast cancer in family, it is better to refer her to the genetic services. This I took it from the Green Top, but I think it looks like an important point. So, so any postmenopausal female who develops symptoms within the last 12 months, that suggests either she's more than 50 years, okay? She developed irritable bowel syndrome. She has significant family history of ovarian, breast cancer, or bowel cancer. Um, then she needs to be referred, and she needs to be investigated. Ask for transvaginal ultrasound. If the ovarian cyst is found, then the next step is serum CA125. Now, CA125, carcinoantigen 125, a tumor marker. It is usually a tumor marker for serous cyst adenomas and adenocarcinomas, but it can be elevated in other cancers and other conditions, which is not cancer. So it's not very specific, but it has high sensitivity and specificity in ovarian cancer. So more than 80% it will be elevated, first of all, in ovarian cancer. So, and if we go according to the cutoff level of 30 international unit per ml, if we use this cutoff, then the sensitivity is 81% and specificity is 75%. And but there are some drawbacks, like it is raised in only 50% in stage 1. So at 50% in stage 1, it will not be raised. And so we cannot use it as a screening tool. Yes, if we found an ovarian cyst, then in order to calculate the RMI, we have to do CA125. So what are the ultrasound features that because we have to give the score in order to calculate RMI. So what are these features? If the cyst is multilocular, if it is bilateral, if it has solid areas, nodules, or papillary projections inside the cyst, and if she has ascites on top of it, and if we found any metastasis, then this is high risk features. Now, I took it from the Green Top guideline. So the summary of this is, it's a very busy slide, so just listen to me instead of looking at it. So the role of, you can do ultrasound, which is the grayscale imaging, but the role of Doppler in 3D is not established. So we should not do routinely Dopplers, spectrum, power Doppler, and the 3D scans for the initial screening. And what about the role of CT scans and MRIs? For the initial evaluation, all these things is not needed, initial screening. But yes, it might be needed later on when this ovarian cyst turn out to be an ovarian cancer by the RMI. Now, what is RMI? So in this, we have to multiply the ultrasound points with the menopausal status and CA125 level. So if we are giving 0 point, if the score is 0, we will give 1 point if the score is 1. We will give 3 points if the score is 2 to 5. And each point is like, if it is a multilocular cyst, it will be 1 point, bilateral cyst, 2 points. So if she has 2 points positive, or she has presence of ascites also 3 points positive, then we have to give her a score of, we have to give her the point of 3 if the score is 2 or 3 or 4 or 5. So the point will be 3. So this is how we calculate RMI. And then if it is a premenopausal, we will give her 1. And if it's postmenopausal, give her 3. And then we'll multiply all of these two things with the level of CA125. So what is the conservative management criteria? Can we manage an ovarian cyst conservatively? Yes, if it is simple cyst and it is unilateral cyst. The size is less than 5 centimeter. Now there is a little bit difference, which I will tell you between the RCPI and RCOG. So recently they changed this one, but in RCPI it still says less than 5 centimeters, so it's okay. We'll take it. And if she has normal CA 125, so the malignancy risk is less than 1%, so it's a low risk. So we can follow her up 3 months and then every 3 months for 2 years. We can manage the patient conservatively. Now, this is what Green Top says. If the patient is asymptomatic, having a simple unilateral cyst, unilocular cyst of 3 centimeter or less in diameter, and this is the update in December 2025, and it means that she has a low risk of malignancy and she do not require any follow-up. Second option, asymptomatic, simple, unilocular, more than 3 centimeter, but less than or equal to 5 centimeter, but normal CA 125, then she can be managed conservatively. This is the new update of Green Top guideline. So manage conservatively here, they mean that repeat evaluation, not in 3 months like RCPI, 4 to 6 months, and for 1 year. And and then discharge the patient if the cyst remains unchanged or it reduces in size and the CA125 is still the same. And we'll discuss with the females, of course, before we discharge her. But if the female is symptomatic, then definitely surgical evaluation is necessary. Now, a woman with suspicious or persistent complex adnexal mass needs surgical evaluation. We are not talking about simple ovarian cyst anymore. We are talking about complex adnexal mass. Then, of course, there's a high risk for malignancy and she needs to be evaluated. We cannot do conservative management. So low risk malignancy index, we can go for laparoscopic oophorectomy with removal of ovary. It should be removed intact in a bag, in a laparoscopy bag, and it can be managed in general gynecological unit. But if it is moderate, then laparoscopic bilateral syringectomy should be done and in a cancer center. And high RMI means full stage laparotomy in cancer center. So when should we operate? If the CA 125 is rising, the size of the cyst is increasing, and it's not meeting the criteria of conservative management, then we need to operate it, or if the patient requests. Should we aspirate it? No, because there is a risk of rupture. Sensitivity is only 25% by checking the cytology from the aspiration. The sensitivity of this is only 25%, and then it can upstage the malignancy. So no. So on transvaginal ultrasound, when we say simple cyst, it means that it should be round or oval shape. It has a thin wall. It should have posterior acoustic enhancement, which is the white, uh, what you call it, because the cyst appears anechoic or dark under ultrasound. So if it has bright shadow under it and it appears bright, it is called enhancement. So this is one of the criteria of simple cyst. And anechoic fluid which looks dark, and the absence of septations or nodules. There are no septations, no nodules inside the cyst. Then it's called a simple cyst. And it is important for management. So if it is a simple cyst, then it can be benign in 95 to 99% of postmenopausal women. When it is complex, it means it has septations, like it is multilocular cyst. Complete septations, because there might be partial septation, which sometimes is not pointing towards malignancy. It's not so worrisome as compared to the complete septation. Solid nodules, papillary projections are all worrisome. There is an alternative of RMI, which Green Top guideline talk about, is aorta, a logistic regression model. Okay. So it's a very busy slide, but I took it from the guideline and from the green top guideline just to show you the difference between RCPI and and the RCOG. So here they measure the CA125. For example, of postmenopausal ovarian cyst patient, they measure CA125, which is the same like RCPI and RCOG. And then they do the transvaginal ultrasound or transabdominal according to the size of the cyst, and they calculate RMI, which is the same like RCPI. Then they go and even at the end of the guideline of RCPI, they talk about it also, which is mentioned here. If the RMI is less than 200 or 200 or more than 200. So if it is less than 200, it is low risk of malignancy. 200 or more than 200 is increased risk of malignancy. So what you do for low risk patient, and if the cyst is fulfilling the criteria of a simple cyst, and she's asymptomatic. Now here they divide it into simple cyst, which is more than 3 centimeter, and 5 centimeter or less than 5 centimeter. Because if the cyst is simple, unilateral, unilocular, less than or equal to 3 centimeters, they discharge the patient. They do not even do the follow-up in RCOG. So here, if it is more than 3 and less than or equal to 5, they do conservative management, but not every 3 months like RCPI. They do every 4 to 6 months, and they bring the patient, they do CA125 level, they do the transvaginal scan, and if the cyst resolved, they discharge the patient. If it is persistent, unchanged, they will again call the patient and might discharge the patient after discussing with the patient, and then and if there's any changes, then of course we have to consider the intervention. Then if RMI is 200 more than 200, which means increased risk of malignancy, and we have to ask for the CT scan to see if there is any spread or metastasis, and the referral for the gynecological oncology cancer center and for the multidisciplinary team review. So if the MDT review says high likelihood of ovarian malignancy, go for laparotomy, full staging laparotomy. And if the MDT review says low likelihood of ovarian malignancy, just go for laparotomy, do total abdominal hysterectomy, bilateral salpingophorectomy, omentectomy, and uh, peritoneal washer ascites cytology by a gynecologist. Okay, and this is how they calculate, which we already discussed how to calculate the RMI. This is, I'm just telling you because the slide is a little busy. So full staging, um, we should know what is included in full staging. So it's a midline laparotomy, it is total abdominal hysterectomy, bilateral salpingophorectomy, infracolic omentectomy, pelvic washing or ascites for cytology. And lymphadenectomy, it is selective pelvic or para-aortic lymphadenectomy. And then appendicectomy, if it's a mucinous cystadenocarcinoma, then we can also have to do the appendicectomy to see maybe sometimes the cancer is coming from there. So SPA, the first one, if the patient is 62 years old, she has 4 centimeter of simple cyst. So it is less than 5 centimeter according to the RCPI guideline, and she has normal CA 125. What is the best management? What do you think? So B means conservative. So if it is less than 5 centimeter normal CA 125, she should go for conservative management. So the SPA number 2, what is the RMI formula? A, B, C, or D? So it is this one. Ultrasound criteria by menopausal status multiplied by CA125 level. Which cyst characteristic qualifies for conservative management? What do you think? So if it is unilateral cyst, less than 5 centimeter, With normal CA-125, you can do conservative management. And according to RCPI, conservative means every 3 months for 2 years. Which women should be referred for a gynecological oncologist? Of course, moderate and high RMI, because low RMI can be managed by the gynecologist. So what is the best surgical approach for high RMI? Full staging laparotomy. So at the end of the RCPI guideline, I will just read for you some important points from this appendix. So let's say, what are the symptoms of ovarian cancer? So we have to consider ovarian cancer in a female if she's more than 50 years of age and who present with the persistent and frequent symptoms. Like, frequent means that it is coming more than 12 times per month. This is, they call it frequent. So if she's having abdominal distension, and it is usually persistent abdominal distension, she is having early satiety, which is a sign of cancer, and weight loss, of course, loss of appetite, pelvic or abdominal pain, and increasing urinary urgency or frequency, or new onset irritable bowel syndrome. So even these vague symptoms, consider ovarian cancer. So also, if the patient is having unexplained ascites, she develops DVT, and she has change in her bowel habits, weight loss, fatigue, which are vague symptoms. I mean, but you have to consider ovarian cancer. Ask for the ultrasound and CA-125 if there is an ovarian mass. So we will not do CA-125 if a female has no symptoms, and so because it can be elevated in many other benign conditions. And it is not an adequate ovarian cancer detection tool. It is raised in 80% of, we already talked about it, that in 80% of epithelial, actually serous cystadenomas or cystadenocarcinomas, it will be raised. But in early stage, 50%, it might not be raised in only 50%. So pelvic ultrasound is required to evaluate in ovarian mass, and an urgent ultrasound is needed when CA-125 is elevated in symptomatic women. So we have to rule out the malignancy. And we are not worried about premenopausal ovarian cyst, which is almost always benign. So the GP should refer the patient directly to gynae-oncologist in these conditions. So if the clinical findings reveal a pelvic mass or unexplained ascites, and which is not fibroid, so refer directly to the gynae-oncologist. If an ultrasound is suspicious for ovarian cancer, and so we can also refer. The GP can also refer. If the CA-125 is more than 200 K international units per liter, then also we have to. Now, this K international unit is same like the international unit. So if it says 200 international unit or 200 K units, it's more or less the same, because that one is international unit per ml and that one is K unit per liter. But this one is the same. The 200 cutoff. So if CA-125 is more than 200, we also refer her to the gynae-oncologist. If CA-125 is 35, but it is rising, and but pelvic ultrasound is normal, it's continuously rising, so we need to refer the patient also. So the GP can refer the patient to the gynae-oncologist. Okay, let's see. Another interesting appendix So the GP referral pathway for symptomatic women. So we have to take first the history and clinic examination, bimanual pelvic examination. Then if the history suggests ovarian cancer, but the examination is normal, like uterine size and tenderness, everything is negative. So we still have to measure the CA-125. So if the CA-125 is like more than 200, of course, urgent referral to gynecologist. And even if there are clinical findings like ascites or pelvic mass, urgent referral. And if CA-125 is 35, not 200. So we have to see, so the cutoff is 35 or more than 35. So we have to arrange urgent ultrasound of pelvis. And if ultrasound is, we find some findings, benign findings in ultrasound, so the gynecologist can deal with it. And if the ultrasound is normal, then we have to repeat the CA-125 in another 6 weeks to see. So when the CA-125 is rising, then gynecological referral, but maybe not urgent, but needs to be referred. And if it is unchanged, then the general gynae referral. There is one more thing, that if the ultrasound of pelvis suggest cancer, ovarian cancer, then also needs to be urgent referral to gynecologist. So if the CA-125 level is less than 35, then we have to assess carefully to see the what if there is any, like, what is the other causes of the symptoms. If there is any other cause of the symptom, we'll investigate according to this, and there's no other cause of her symptoms, we will return the patient back to the GP for further assessment. So this is a very comprehensive and nice tables, these two. So just go through them again, but the points that I told you, not each and everything needs to be. So thank you very much. So we discussed 2 guidelines, and next time we'll discuss more guidelines. Thank you for your patience, and see you again. Good luck.